Welcome. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website, www.nahatica.org, within your webinar library. In terms of certificate, after completing this webinar, please complete the quiz. If you're interested in receiving a certificate, you can find the quiz on our website next to the Watch Now button. You selected to view this webinar on our website. If you are a member of Nahatica/NADAC, the certificate for this webinar is free. If you are not a member, the fee is $15. If you receive a certificate worth 1 CE, you will receive a certificate worth 1 CE once you've completed and passed the quiz and paid for the webinar if applicable. To the New Hampshire Training Institute on Addictive Disorders, this 1-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Other Drug Use Professionals, as well as NBCC. In terms of technical support, if you have any trouble viewing this webinar, audio problems, or any other technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to traininginstitute@nahatica.org. So welcome once again. The topic here today is harm reduction. My name is Canid Hernandez, and I will be the presenter for today. Thank you for your interest in this topic, and hopefully you're going to do some learning regarding this topic area. A little bit about myself. I am a professional trainer. I've worked in the field of substance use disorders and mental health for the last 32 years. I've worked in inpatient settings, outpatient settings, not-for-profit settings. Currently, I do a number of things, including the fact that I direct a program that trains Latino folks who want to become certified drug and alcohol counselors in the state of Massachusetts. And I do some consultation on a number of SAMHSA-funded projects. I am a certified prevention specialist, and I am a certified and licensed drug and alcohol counselor at the reciprocal level. And I have a PhD, and my background is in public health, human services, and counseling psychology. But I also have a GED. And by GED, I got in prison, and it was more difficult to get a GED in prison than to get a PhD out here. And so that for me is connected to the fact that I'm a person in long-term recovery. And what that means for me is that I haven't used a substance, including alcohol, for the last 33 years. What that has enabled me to do is to be a productive member of my family, my community, and to be able to do this type of work. You can look for me on Instagram or Facebook. My email is right on the cover page, as well as my telephone number. And I'm excited about presenting this really important topic. In terms of the learning objectives for this webinar, participants will be able to describe the philosophy, principles, and practice of harm reduction. You'll be able to describe at least 2 techniques and strategies for engaging people in harm reduction. You will be able to describe disparities and the need to address and build health equity. You will be able to describe your role in promoting, supporting, and sustaining meaningful change as it relates to recovery. And you hopefully will be able to name at least 2 resources for harm reduction. Just want to ground the conversation in the Institute of Medicine. continuum of care. And so it begins with promotion, followed by prevention, treatment, and maintenance. Some of you might be, and across this continuum, there is the opportunities to do promotion. And um, some of you might be more familiar with the model of prevention, intervention, treatment, and recovery supports. And you can overlay that model on top of this one if you're more familiar with that one. But here in the area of promotion um, is everything that we do to promote wellness, recovery, well-being, that sort of thing. The area of prevention, we're talking about universal, selective, or indicative types of prevention. In terms of treatment, we focus on case identification, a standard of treatment for known disorders. So you might want to think about what those are as we think about harm reduction. And in terms of maintenance, we're talking about compliance with long-term treatment and what we now know as recovery supports, or here it is spoken about in terms of aftercare, including rehabilitation. So let's have this in mind as we think about and discuss issues of harm reduction. There's a definition of harm reduction from SAMHSA, and as you may know, SAMHSA is the Substance Abuse and Mental Health Services Administration at the federal level. Harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. And we know that there are plenty of negative associations, negative outcomes that are associated with drug use. And a lot of what is in the public sphere today and constantly in the media, and rightfully so, are opioid overdose deaths as a consequence of drug use. So that's just one of those. In terms of harm reduction, it is also a movement for social justice built on a belief and respect for the rights of people who use drugs. And so this is not just a set of strategies, techniques, that sort of thing. It's actually a social movement addressing issues of social justice. And that has implications for how we understand and engage in harm reduction strategies and techniques. We'll talk a little bit more about those later on in this webinar. There are a number of principles of harm reduction that SAMHSA advocates for, and we do too. And it's an understanding that, for better or for worse, illicit drug use is a common societal problem that is not going away anytime soon. So drugs have been around for a very long time. And even though we are engaged in many different fronts, drug use will continue to happen. Hopefully diminish, and in some cases, in many cases, hopefully we will be able to support recovery and people don't have to use substances, but there will always be people who use substances in society. There's a spectrum of harm reduction strategies ranging from safer drug use, i.e. syringe exchange programs, to abstinence. And so it's important here to mention that in this spectrum, many people in society, when they hear harm reduction, what they hear is we are condoning drug use, and that we're just teaching people how to use safer and they'll continue to use. And that is not 100% accurate. There'll be some people who will learn how to use safer, and that's their goal. We should be able to support that. But there will also be people who are seeking abstinence and everything in between. And so, again, we draw emphasis in terms of the spectrum. Harm reduction strategies should have simple or low threshold entry requirements. Examples include bring services to spaces and places where people who need services already are. If you think about many of the substance use disorder treatment services, we require people to come to us in an office. They have to make an appointment, that sort of thing. While harm reduction strategies seek to be within the community. In In other words, let's meet people where they're at, where they are, and where they are more accessible. People who use drugs have a real voice in the creation of policies and programs. And this is a real important piece. For the most part, treatment programs in the US have been developed by treatment professionals with very little to no participation from the people who need those services. And so, again, this principle is really important because we want to bring in the voices and experience of people with lived experience in terms of using substances in how we create, deliver, and evaluate programming. So, we need to move into framing this issue in terms of we're trying to reduce harm from what? And so, obviously, we're talking about substance use disorders, mental health, and other health conditions. But what specifically, right? So, again, substance use and mental health conditions. We should also think about HIV and AIDS because we have seen and we continue to see upticks in HIV infections across the country due to injection drug use and other practices, which include sexual behavior. So we're looking to reduce harm from HIV/AIDS and as well as other sexually transmitted infections and diseases. The people who work on harm reduction just don't focus on one thing. And so you might see people who come in and we're teaching them around harm reduction regarding substance use, and we focus in on issues of sexually transmitted infections because we want people to be healthy for the point in time where they're ready for recovery. Another area is hepatitis, all three of them, A, B, and C. A huge concern in our field right now is hepatitis C. The CDC reported in 2018 a 300% increase in hepatitis C cases, particularly amongst young people who use injection drug use and other substances. And we know that there are approximately 5 to 7 million people infected in the US with hepatitis C, and about 75% of them don't know their status. So helping them to get tested and to understand their status and get into treatment is a form of doing harm reduction. And there are a number of other health conditions that we know that the people with substance use disorders and mental health issues are exposed to, including diabetes, hypertension, and other health conditions. And it's important for us to understand what those are and their connection to wellness, recovery, that sort of thing. So these are the areas that we are very concerned with, and you might be thinking about other areas as well. And so I mentioned earlier opioids, and I want to go back to that to talk a little bit about what that looks like right now. And so in the news and in our field, we're talking a great deal about the fact that we have an opioid crisis. And what I like to explain to people and draw attention to is that when we have myopic views of what the situations, problems are, or challenges in society, we come up with myopic solutions. And so I usually ask people, do you think that we have an opioid crisis? And most people in the audiences where I ask those questions, they say yes. And I follow that up with respectfully disagreeing that we have an opioid crisis. Because in the literature, and those of us who are doing work in the front line know that the crisis is a little bit more complicated than just opioids. We have a crisis of over-criminalizing substance use disorders and mental health issues. We have a crisis in health, like all of the other areas that I mentioned earlier, HIV, hepatitis C, diabetes, and other health conditions. We also have a crisis in employment opportunities for the people that we work with who are in or seeking recovery. We have multiple crises at the community level with the lack of education programs and access to them for folks who are in recovery or seeking recovery. We certainly across the country have a crisis in affordable housing where it's very difficult for working folk, poor people to get housing, and it's even more difficult for people with substance use disorders and mental health issues. And obviously, we have a crisis in mental health. And so I want to come back to issues of opioids. So do we have an opioid crisis? Yes, but we also have a crisis in substance use disorders. And so our folk are struggling with alcohol and alcoholism. Our folk are challenged with using methamphetamine and other substances. And so it's not just opioids, whether those are prescribed or not. We have people who are injecting fentanyl, and most of the opioid or overdose deaths are connected to fentanyl. So hopefully you can now see why I insist that we should not be myopic in saying that we have an opioid crisis. We should be a little bit more comprehensive in understanding that we have a more concerning degree of issues and challenges that we should be concerned with and addressing. And so as we think about harm reduction, there are opportunities to do harm reduction in many different areas and not just opioids. It's not that simple. It's a little bit more complicated. Another piece that I want us to think about is how we claim we treat people. And the we here that I am suggesting is people who work in health and human services, and that includes all of us who work with substance use disorders and mental health issues. And so we claim that we're non-biased. Have you ever heard people who say that they're non-biased? I used to say this a great deal. I don't say it anymore. Have you heard the people who say that they're non-judgmental? You probably said it in your lifetime. I have said it multiple times. I try not to say non-judgmental anymore, that I'm not judgmental anymore. That we treat people as they come or meet them where they're at. I know where this comes from, but we need to recognize that we're agents of change. And treating people as they come lasts for about 2 minutes, as far as I'm concerned. We also say a great deal, we want to treat people as we want to be treated. This is known as the golden rule. The variation on the golden rule is treat people as they want to be treated. I used to say this a great deal. I don't say it anymore. And my personal favorite is when people say, I treat everybody the same. Again, I used to say this a great deal. I don't say it anymore. So why do I continue to say throughout this presentation that I don't say these anymore? Because I think that these are feel-good measures or ways of thinking and saying things that don't get at how we should be treating people and how we should acknowledge the issues that we as helpers bring into the room. So for example, are we biased human beings, that is? Yes, we are. We learn bias at home, in school, in community, in places of worship. And so we internalize bias in many different ways. And to say that I'm not biased is not to be accurate in the reality of human beings. Am I judgmental? Of course. I judge situations, I judge issues, I judge people, I judge thought processes on a daily basis. Not to admit that doesn't make it go away. When I admit that I am judgmental and that I am biased, then I can do something about it. And so when we combine bias and judgments, then we have a recipe for disaster. And so this is a look inward. Treating people as they come sounds good, but again, we are agents of change. Meeting people where they're at, that really is inaccurate, particularly for those of us who work in offices where people come to us and they have to make an appointment. And then they go home or into their communities to practice, hopefully, some of the things that we talked about. So, is a call for thinking about this a little bit more critically. Uh, Treating people as we want to be treated. Listen, I am a 55-year-old Puerto Rican male, and I doubt it that you want to be treated as a 54-year-old Puerto Rican male. Um, and the variation on this is treat people the way that they want to be treated. Well, some people are attracted to um, violence. They're attracted to um, not healthy relationships. They're attracted to being treated in bad ways. And so we know how people develop um, these issues, right? And so I doubt it that we should be treating people the way that I want to be treated, or in many instances, the way that they want to be treated. And every single person listening to this webinar is different from the other, and we're not all the same. And so we shouldn't be treating everybody the same. We should be taking a lot of things into account, including our own biases, our own judgments, where we provide the services and how. We should be taking into account internalized oppression, and we should be taking into account that people are different culturally and in many other different ways. And so we shouldn't be treating everybody the same. We should be treating people with dignity and respect, and we should be identifying what their needs are and working from that perspective. The other area, one of the other areas that we want to couch this conversation is in the reality of disparities, right? And so the definition here from Healthy People 2020 is that disparities are a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systemically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. I know that that is a mouthful, but we should understand that at the federal level, through SAMHSA, HRSA, CDC, and other federal agencies, as well as at the state level through local health departments or state health departments, and at the local level with local health departments, that sort of thing, there is a greater emphasis in understanding disparities. I know that this webinar is about harm reduction, but we need to make the connections with how people experience health or lack thereof in today's society. And so we need to understand that, again, not everyone is the same, that they bring with them all of these characteristics that are described here or different ones, and that historically some people have not gotten access to prevention, intervention, treatment, or recovery supports, and that puts them at a disadvantage. More importantly, that has created disparities over hundreds of years in this country and in other parts of the world. So it's important to understand that disparities did not develop yesterday, 10 or 15 or 20 or 30 years ago. They have developed over hundreds of years of experience with lack of access and quality of care. So we arrive at a discussion question here. And I'm going to read it, ask you to think about it, and provide your best answer. People who use substances should participate in creating policies and programs that treat addiction. True or false? So, the belief is, as you saw from one of the previous slides from SAMHSA and practitioners such as myself and others in the field, is that as much as possible, we should engage people who use substances in the participation of the creation of policies and programs that treat addiction, because because when we decide what those programs are and what they should be and how they should be implemented, um, in the absence of the people with lived experience, we are most likely to miss the target in terms of how a particular policy or program should be developed and implemented. Programs are made stronger, policies are made stronger when we include the identified population in their development. Thank you for participating in that discussion. Question. Back to issues of disparities, there are individual factors associated with disparities. They include all of the issues that I talked about in the previous slide, which include race and ethnicity, religion, socioeconomic status, ability, gender, age, sexual orientation, gender identity, and of course other characteristics historically linked to discrimination or exclusion. And so you see that these individual factors are not just one. And so when many people hear us talk about disparities, they primarily think about race and ethnicity and maybe issues of language. And those are at the center of individual factors associated with disparities and cultural factors associated with disparities. But there are all of these other ones that are listed here. And so we should be well-rounded in thinking about what those individual factors are and how we can impact those individual factors so that we can address disparities in a meaningful way. There are social factors associated with disparities that we should pay attention to as well. And those include education, neighborhood conditions, environmental hazards, access to prevention and treatment, health insurance coverage. Let me take a couple of these to give some examples. And so I live in Massachusetts where 98 to 99% of people have health insurance. Having health insurance doesn't necessarily mean that those people with health insurance are going to gain access to prevention or treatment opportunities. And even those that do gain access to treatment doesn't mean that they're going to get quality of services. And so access to treatment and quality of care are two different things. And so the examples of social factors, right? For the most part, in our field of substance use disorders and mental health, we have placed the emphasis and the onus on individuals to get better. In other words, people say, well, if Janet got better, why can't you get better? And that is a really punitive way of seeing things, given what we know about the social factors associated with disparities and issues of recovery, right? And so are there those programs available at the community level for people to gain access to? And if they are, what's the quality of care? What are the neighborhood conditions in relationship to parks, to healthy foods, to education, to having spaces and places that are free of environmental hazards? And so many communities, people want to get better, but the conditions are not there that support issues of recovery. So we should always think about the social factors. And as we think about and discuss issues of harm reduction, how can we reduce harm so that people can gain access into services that they have the right to participate in and have made available in their communities. I want to just talk a little bit more about some examples of disparities as we move toward this conversation of how to address disparities. It's important to come up with some additional examples of what this means in practice. Earlier on in this presentation, I talked about hepatitis C. And so there are 5 to 7 million people in the US, as I mentioned before, who have hepatitis C. There's a disproportionate number of them who have used substances, primarily injection drug use. And so we see disparities in hepatitis C. There's a belief that the majority of people with hepatitis C are baby boomers. So we see disparities in the different populations that experience hepatitis C. And as I mentioned before, CDC in 2018 reported a 300% increase in hepatitis C cases. So we see that there are disparities there, and that we should understand disparities as it relates to race, gender, issues of age, as I mentioned, the baby boomer example, right? So those are examples. Another example that usually comes up, I talked about earlier, is disparities in HIV/AIDS. And so this country and other countries have done a really good job in reducing mortality, morbidity rates as it relates to HIV and AIDS. Yet, we have seen increases, most recently in the state of Indiana and here in Massachusetts, in increases and spikes in certain towns and cities of new infections of HIV, and that is connected to substance use, primarily injection drug use. And so we see disparities there. When we dive into the data a little bit more, we know that most of the new cases of HIV/AIDS are occurring amongst men of color who have sex with men. So we see disparities in those populations as well. Again, you see the intersections here of age, we see the intersections of race and ethnicity, and we also see the intersections of what communities have access to resources versus those communities who don't. Another example of disparities as it relates to opioid overdose deaths is that in my state, the state of Massachusetts, for the last few years, mortality, deaths related to opioid overdose have gone down for the general population. Last year, 4%, the year before, 4%. And that is a good thing, that mortality rates are going down. But when we took a look at the data for African Americans, deaths by way of opioids between 2015 and 2018 went up 83.3%. And for Hispanics and Latinos within that same period, deaths went up 100%. And so we see disparities in who's dying. And again, drawing your attention to the intersections of race, ethnicity, and other factors as it relates to those disparities. So just wanted to pick on those few disparities so that we can develop some critical thinking about the fact that it's not accurate when people say that addiction and mental health issues don't discriminate. They do, because systems and individuals do discriminate. And so it's not that Hispanics and African Americans don't want to get better, or that they don't want to use Narcan. The question becomes, are those harm reduction methods accessible to all people, regardless of race, ethnicity, and the other factors that we talked about? And the answer to that is no. They are not available to all people in the same way. Another huge example in relationship to disparities has to do with mass incarceration. And so in 1970, there were 200,000 people in the US incarcerated. Fast forward to 2019, and there are 2.3 million people incarcerated in the US. This is a huge increase. Then the question becomes, what happened between 1970 and 2019 or 2020 that we see this huge increase in people who are incarcerated? But what didn't happen is another way of phrasing the question. It's important to also understand that there are approximately 5.5 to 6 million individuals on probation, parole, or house arrest. And so again, we pose the question, what happened between 1970 and 2019, that we have seen an increase in the prison population. We have the largest prison population per capita in the world here in the United States. You know, one thing that did not happen between this time is that crime rates went up. Actually, people who study crime have reported that between 1970 and 2019, crime has gone down. So why has the prison population increased in these significant ways? And so there are what I and other people who do research call deliberate policies. These include deinstitutionalization, the closing of mental health hospitals at the state level. And so the law that created the pathway towards deinstitutionalization was signed into law by then President Kennedy in 1960. And part of that law talked about the fact that we would reintegrate people with mental health issues into community. The first part happened, the closing of the state hospitals did happen, but the second part, in terms of reintegrating people into community, didn't happen. And what we end up with, by some accounts, 60% of people with mental health issues are incarcerated in U.S. prisons and jails. 1970, the war on drugs, Richard Nixon signed this into law, which in fact came with teeth, and it said that we're going to criminalize behaviors around drug use and sales of drugs, and we're going to put people in prisons and jails. And so we criminalize behaviors that at some point in history were not criminalized, and we see some of this happening today by way of outlawing or banning panhandling in cities and towns across the U.S. That is in fact the criminalization of behaviors. The differences in sentencing in powder versus crack cocaine, these are policies that came out of the 1990s, and the largest crime bill signed into law by then President Clinton. And we have seen what these have done to people who are caught with small amounts of powder or small amounts of crack cocaine, different from powder cocaine. And we have developed mandatory minimums, 5, 10, 15, 20 years of mandatory sentencing across the U.S. We have stripped people of voting rights for being convicted of a felony. We have also developed school zones, which attaches 2 years of mandatory sentence to the original sentence for being caught selling or possessing drugs or attempting to sell drugs in school zones. And by the way, school zones operate 24 hours a day, even when schools, parks, daycare centers, those sorts of things are closed after operating hours. 3 strikes and you're out. This is 3 felonies and you're doing life in prison. And there are people who are currently doing life in prison. One of the most famous cases of the 1990s was this one guy out of Texas who got sentenced to life, and his 3rd strike was that he stole 2 slices of pizza. This is a person who was experiencing homelessness. Massive prison construction, because in order to house 2.3 million people, we need to have a lot of prison construction across the U.S. And then there's the privatization of prisons and jails. And so prisons and jails that are privatized are traded on the New York Stock Exchange, which means that people are profiting from the misery of people being in prisons and jails. And so there is an incentive, many of us think, to keep people coming back to prisons and jails because they are for profit, which means that the uniforms, the food, the commissary, phone calls, all of those things are privatized, and people are making money off of the misery of others who are incarcerated. And we would be remiss if we don't mention criminal offender records. And so every state has their laws in place around criminal offender records. And so if you're coming out of prison, jail, or the criminal justice system, and you have felonies or even misdemeanors that are related to the use of substances on your criminal record, they make it very difficult for people to get housing, employment, again, voting rights, student loans at the federal level, access to be able to get their kids back from the Department of Children and Families, those sorts of things, and they disproportionately impact people with substance use and mental health issues. And there are many other examples of deliberate policies that have been put into place. So we should think about what this means in practical ways by way of doing harm reduction with people, and what is the impact of these deliberate policies on communities. That's not all of it, by the way. And so in 2018, there's a study that came out that talk about so-called plea bargains. And that is when the prosecutor offers you a plea bargain for admitting guilt in a crime or pleading guilty in a crime. You see from the slide that 97% of all cases at the federal level are pled out, 97%. At the state level, is 94% of those cases that are pled out, which means what? That people don't take these cases to trial. They plead out because your judge, your lawyer, which for many poor people happens to be a public defender, comes to you and says, the DA, the district attorney, is asking for 15 or 10 or 5 years mandatory. If you plead out, I can get you a lesser sentence. What do you want to do? And some people might say, well, they're choosing to take the lesser sentence, but is it really a choice, a free choice, when you're being told, take 5 years, if not, you're going to get 15, or take probation, if not, you're going to get 5 years. And so it's easy to see how people plead out to these deals that are not really deals, because they saddle people with a criminal offender. And so, in all of this discussion, we have talked about issues of policies and what they mean to people and what we should be doing to address issues of disparities, which include disparities in mass incarceration. And so just to bring the point home in terms of what this looks like, this next slide looks at young male incarceration rates in 2018. And by the way, there are plenty of women incarcerated in the US. It just so happens that the majority are males. And this data speaks about males. So thinking about the number of people, in other words, young males, incarcerated between the ages of 25 and 29, and this is per 100,000 in that age group, right? So take a look at what it is for whites, for Caucasians, 1,437. Take a look at what that same incarceration rate is for Latinos or Hispanics, 3,892. It spikes up significantly, right? More than half. And then look at what it does for African Americans or blacks in this country. 8,932, very close to 9,000. So there we see the disparities in what incarceration looks like for young males. And if you're not alarmed by what this does for primarily people of color, you should be. And if you look at the number for whites being low, 1,437, it should alarm us as well, because we're talking about poor whites. The majority of people who are incarcerated in this country are in fact poor whites. And so all of these numbers should alarm all of us. And there's ways that we can engage with people at the community level to emphasize harm reduction strategies and techniques, so that our people, A, if they're going to use substances, use a little bit more safely. And if they choose to do abstinence, what are the steps and strategies that move towards that goal of abstinence? And if they choose to enter into a pathway, for example, of medication-assisted treatment or medication-assisted recovery, how can we support them with harm reduction strategies that keep them out of the judicial system in the US? In other words, what are the harm reduction techniques that we can use with people, not just men, but women and society in general, to minimize their contact with crime, to minimize or eliminate their contact with incarceration rates in the U.S. And so this, again, slide brings that picture home in terms of how mass incarceration impacts different people of different races and ethnic groups in different ways. So if disparities are the problem, we need to move towards a place where we address issues of health equity. And so again, providing you with a definition by SAMHSA, the Substance Abuse and Mental Health Services Administration, of what equity is, right? And so behavioral health equity is the right to access quality health care for all populations, regardless of the individual's race, ethnicity, gender, socioeconomic status, sexual orientation, geographical location, and social conditions through prevention and treatment of mental health and substance use conditions and disorders. And at the heart of this is, again, we go back to those characteristics that exist within populations, right? Issues of race, ethnicity, gender, socioeconomic status, or sexual orientation, geographical location, and other social conditions that I have been talking about throughout this webinar. So we need to think about what equity looks like and how do we participate as responsible people in issues of building health equity for the populations that we work with. And so a depiction, a visual depiction to develop some critical thinking is these individuals trying to watch a baseball game, right? And so I'm going to take you through these slides rather efficiently so that we see what's being presented here, right? And so first and foremost, I want to take you to the side that says equality. And I usually ask people, what do you see, what do you say, what do you question, what do you think about that portion of the slide, equality. And so people immediately point out that the three people trying to watch the game are of different heights. And because they are of different heights, only two can see over the fence, the tallest person there and the person in the middle. And the smallest person cannot see over the fence. And then what other people point out is that all of them have access to the three same resources. In other words, the three boxes. And so treating people, giving them the same thing doesn't necessarily address the challenge or the problem, which is, in this case, seeing the game of baseball. And so I usually ask people, and this is a question for you who is participating in this webinar as well, do you think equality exists? And I will ask that multiple times, do you think equality exists? And so some people argue yes, they say yeah, because, you know, I got the same resources as everyone else, and I just made special use of them, and so, you know, I gained access to recovery, and here I am. And other people will say, yes, you know, I have a degree, college degree, everyone in my school was treated equally, and everyone could have gone to college, but some people decided not to go to, so equality exists. And then there will be some people who will say, no, equality does not exist, because not everyone starts from the same place. And even if you provide the same type of resources to everybody, people have differing needs. And so my response to that conversation is equality exists only in the minds of people with privilege and power. I'm going to repeat that. Equality exists only in the minds of people with power and privilege. These are the folks who get up in front of groups and say, if I did it, anybody can do it. If I got this, anyone can do it. And they fail to understand that there's a reality operating on the ground. And so I'll take you to the far right of this depiction that says reality. And I ask people, what do you see? What do you say? What do you question? What do you think about this side of the ledger? And for the most part, people will say, well, I see that the smallest person there now is now in a hole. And so that is a depiction of a person who's in the ditch. And so what I say to that is the following. Some people, even before they're born, they're relegated to a ditch. In other words, there are people who live in conditions, in communities, where the resources are not there. And so the other example that I provide is that there are people who work two, three jobs and will never make the same amount of money that I make in one day or per hour. And so the reality for some people is that it doesn't matter how hard you work, you're going to be in that ditch because the conditions that have been created by way of policies and poverty and the relationships between the two um, don't allow for people, for all people, to come out of that ditch. Now, granted, there are some people who are born or come out of that place of not having resources and then make it out. But the argument is that that is not the majority of people who live in poverty. The majority of people who live in poverty without um, the right supports and resources will live within those conditions regrettably and unfortunately for their lifetime. And so we see that there are people in the ditch. I ask even more, so what else do you see? What else do you say? What else do you think? And people will say, well, the person in the middle, their situation hasn't changed. They have the same box. They can see over the fence and they can see the game. And then other folk will say, the person who initially didn't even need one box because they can see clearly over the fence without the box now has 7 boxes. And so, people will talk about how unfair that is. And I question people and I ask you to think about yourself. Do you have any boxes? Do we have any boxes? And my response to that is yes. I have degrees, I have a job, I have a place to live, I have information, I have resources, I have health insurance, and of course I have boxes. The question is, how do I use my boxes to help people who don't have resources? And so the other thing that people point out is that, yeah, there are a lot of people in society who have a lot of resources and information, and they're only out to get resources for themselves. And I usually point out that that is not always the case. Yes, there are many people who have resources and they don't care about anybody else, but there are people like us in this room, in this webinar, who have resources, and we seek to help other people. And there are people with a lot of resources who seek to help other people. One example of that is, I don't know if you remember last year, towards this time of the year, when all of the colleges are celebrating their graduations. And Morehouse College, historically black college, invited a keynote speaker to provide the address to the graduating class. And that person, if you remember, what he did, and he's a billionaire, African American, came before the graduating class and said what? He said, I will pay for all of your student debt. Millions and millions of dollars in that room or in that space where he delivered the keynote address. And so people remember what he said, but people don't remember who he was, right? So there are people with resources who go out of their way to help other people. There's another person when in 2016, white, also billionaire, tax reform was going on, and he said, I don't need a tax break. My secretary needs a tax break. And other secretaries need tax breaks because they pay more percentage-wise in taxes than I do. And when I ask people in presentations and meetings, who was that? There will be some people in the room who say Warren Buffett, and they're correct. Warren Buffett said, I don't need resources, I have a lot of them. I will use my resources to help other people, and they do advocacy. And so that's a depiction of reality, is the haves and the have-nots, and what does that look like in society? Obviously here we're talking about looking over the fence and watching a game, but we're actually talking about how do we engage people in the process where they get better and they have access to resources, which brings us to the depiction in the middle, which is equity. And so When I ask people, what do you see? They go, oh, well, now the boxes are distributed differently. You know, people have access to the resources that they need. They seem a little bit more happy because their hands are up in the air. There's a fist bump. The person in the middle is now looking towards the smaller person. And so they look a little bit more happy. And I always ask people, but what else do you see? What else do you say? What else do you question about this depiction? There have been points in times where people point out what I want them to think about, and then there have been points in times where there's silence and people don't know what to say. And so what I have to say is that if we are just playing around with boxes, we have lost sight that what the problem here is not necessarily the boxes or lack thereof. The problem is the fence. And if we don't address the fence, then these people will forever be on the outside looking in. And so the fence represents what? It represents policies and procedures that are put into place that keep people from having access to resources in health, in treatment, in prevention, in those sorts of things. And so, you know, I talk about the boxes, and I understand that those of us on this webinar, part of what we do every day is to help people get access. And so by doing that, we play around with the boxes. But we have a larger responsibility to do capital A advocacy, and is to address issues of the policies and procedures. I'll draw your attention back to the deliberate policies regarding mass incarceration. We can play around with the boxes when people are coming out of jail and try to help them to get access to housing, employment, healthcare, and all of that. And some of us do a really good job at that, but not everyone gets access. Unless we deal with the policies and procedures that land people in the situations to begin with, we will be forever chasing our tails, right? And so that includes embracing issues of harm reduction and how people get better, and how people, and what's our role in terms of addressing those issues. And so our role, I firmly believe, is to approach the work utilizing cultural humility. And these terms of cultural humility and the one that I'm going to address in the next stage, which is cultural intelligence, help us to move away from issues of cultural competency. Because in our field, people have heard cultural competency to mean that I just need to go to one workshop or one webinar and hear about cultural competency, and that's the only thing that I need to do. And so the definition here about cultural humility says what? It says cultural humility incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships within communities on behalf of individuals and the defined population. I know that this is a mouthful, but I'll give you a second to think about what this means for you, right? And so when you see this definition, hopefully you're thinking about what it contains. For me, that includes a lifelong commitment to self-evaluation and self-critique. In other words, whenever I'm helping someone, I bring myself into that process. And I bring my biases, I bring my judgments, I bring my preconceived notions of what it means to get better. I bring my biases in relationship to harm reduction and what that looks like. And so I should be engaged in a process of self-critique and self-evaluation. And how do I do that? For me, for Janet, I do that by way of participating in supervision, by way of speaking to mentors, by way of coming to training, by way of engaging in conversations that are critical, that look inward into me, where I can make some changes. And the second part of this is, how do I engage the community in mutually beneficial, non-paternalistic ways of developing policies and programs and engaging in a process that's beneficial to all communities and not just to one person, right? And so think about cultural humility as we engage in this, or we continue to engage in this conversation of what harm reduction looks like. So we come to the second discussion question. and it's all about syringe access, right? So think about syringe access programs. So do you think that syringe access sites promote substance use? True or false? The answer is false. All of the research, all of the literature that has been done and published in relationship to this issue is that syringe access doesn't increase substance use. As a matter of fact, syringe access programs reduce HIV infection rates, they reduce um, other harms associated with substance use, and they increase knowledge about sexually transmitted diseases, they increase knowledge about the multiple pathways of recovery, they increase knowledge about harm reduction strategies and techniques, and not just knowledge, they increase the practice of them. Because in syringe access sites, they provide information, resources, literature. They help people to understand about wound care, about where the treatment programs are, what to do in terms of when someone has an overdose. They distribute Narcan and teach people how to use Narcan. And so the answer is false. Syringe access sites do not promote substance use, not in theory and not in practice. Thank you for participating in that discussion. Question. This is the piece that I alluded to earlier, cultural intelligence. And here we're talking about it is the capability to relate and work effectively in culturally diverse situations. It goes above and beyond existing notions of cultural sensitivity and cultural awareness to highlight a theoretically based set of capabilities needed to successfully and respectfully accomplish our goals and objectives in culturally diverse settings. And so, again, going above and beyond existing notions of cultural sensitivity and awareness. And there's highlight and theoretically based set of capabilities, which means what? That I need to read what's in the literature. I need to understand the fact that providing syringe access or other forms of harm reduction doesn't condone substance use. It actually helps prevent diseases, death, and other issues. And how do we do that? We do that by engaging in research, by engaging in understanding the literature, what it says, and it also includes engaging with our communities and the people who walk through the door, because they know a lot more about current drug use than we did, even if we are people in recovery. Again, in my experience, I used substances in the 70s and part of the 80s. So do I really understand what's going on now on the ground from a very personal perspective? My answer to that is no. So where do I go to learn that? I learned that from the people in front of me, from what the literature says, from documentaries, from reading, and participating in those processes. So what are some of the harm reduction strategies that we are engaged in right now at the community level as it relates to issues of substance use and mental health disorders? And so one of those things is Narcan. We have made Narcan available to many people. And by the way, Narcan has been around for over 50 years. But right now we've made it available for people who use substances. We made it available for families of the people who use substances. We've made it available to businesses, to health centers, to clinics, to courts, to treatment facilities. And so we've done, in my view, a really good job of making people more aware of it. Yet we still have a long ways to go, because in many communities who are experiencing disparities, Narcan isn't as readily available as it should be. Massachusetts, you can walk into a pharmacy and you don't need a prescription to get Narcan, because we have a standing prescription to get it. We made it available for free for people as well. Another harm reduction strategy that we have are condoms. And we should mention that harm reduction becomes really controversial in two areas, because everyone in society utilizes harm reduction strategies. We're just not taught to think about them that way. But think about this. On your way to your employment today or on your way to wherever it is that you took public transportation or your personal car, did you wear a seatbelt? Did that car, or bus, or train stop at red lights? Or did they stop at parking, at stop signs? The answer to that is yes, then you are using harm reduction. It gets controversial when we're talking about drugs or sex. But condoms is a way that we um, promote harm reduction and engage people in harm reduction activities. And by the way, all of the studies all over the world, including here in the US, when people use condoms and we make them available, they reduce sexually transmitted infections. They actually reduce sexual activity. They don't make people more willing to have sex, as has been said by the people who oppose harm reduction strategies. Needle exchange, I spent some time on this webinar talking about needle exchange, but we're really calling them these days syringe access spaces and places where people come in, they can get clean needles, they can dispose of needles who have been used, but they also get referrals to treatment. They also get wound care. They also get access to clean water. And in some spaces, they have a shower where people can take a shower. People can, who are experiencing homelessness, can come in and wash their clothes. So those spaces and places who do that are not just about needles. They're about comprehensive services that get people in the mindset of getting better and doing better for themselves. And obviously, these things help to reduce hepatitis C and HIV, as we mentioned earlier. There's a new movement towards safe consumption sites in the US. These spaces and places have existed across Europe for many years now, and now there's a case right now in front of the federal courts in Pennsylvania, and they have at least gotten the go-ahead from one federal judge who said that they don't violate the federal law. And so this is making its way through the courts. There are many people on multiple sides of this issue. What the research out of Europe says is that these sites, safe consumption sites, reduce opioid overdose deaths. They increase the probability that people get into treatment and recovery and that sort of thing. And they do not promote or condone the use of substances. Again, this is highly controversial, but it's a harm reduction strategy that I too believe in. It's something to keep an eye on and support people through that process. So how do people change, right? How do people change behavior? There are two researchers, Di Clemente and Prochaska, that took many things into consideration when coming up with stages of change. And among other things, they said individuals go through a logical series of decision changes on the way to adopting new behaviors. This is an important thing to think about, how people change behaviors, and it's connected to harm reduction in many different ways. And so there's a context for stages of change, and that is that Prochaska and Di Clemente say that change is a process rather than an event. When people go through a process, and it's complicated, and it includes cognitive and behavioral processes. In other words, you have to think about what you want to change, how you want to change it, and then you need to practice that behavior change in order to develop expertise, become comfortable, and incorporate it into one's daily living. It can be very challenging, and for the most part, people focus on how challenging it is. I like to focus on how rewarding that process is and focus on strength-based approaches. Change requires education, support, guidance, practice, and a lot of patience. And this is on behalf of the people making the change, but this speaks to what our role is in encouraging and supporting harm reduction. Again, we should be doing education, support, guidance, practice, and we too should be patient with that change process. And so They came up with the 5 stages of change for Chascan Clemente, and I'm going to review those briefly with you right now. One of those is pre-contemplation. In other words, another one is contemplation, preparation, action, and the final one is maintenance. I want to draw our attention to pre-contemplation. These are the folks who are not interested in making any changes, and these are also the folks who might not know that they have a problem. So there's a continuum here, right? I know that they have a problem and I'm not willing to do anything about it, or I don't even know that I have a problem, and that we consider those people to be in pre-contemplation. And so for those people who know that they have a problem they want to continue to use, it's a really good opportunity for us to do harm reduction, right? Because dead people don't recover. And so if we do harm reduction by way of teaching them how to use safely, or how to cut back on using lesser number of hits a day or bags a day, that sort of thing, or how to clean their syringes, or how to gain access to other forms of harm reduction, then people can live in that space until they're ready to do what? To contemplate, into moving into contemplation, into moving about what to do about their condition, right? And contemplation is time sensitive. People plan to do something within the next 30 days. Hopefully, we're helping people to move while utilizing harm reduction strategies and methods to moving towards preparation. This is when people are actually making calls to get into treatment or into a detox, where they're actually making changes and saying, I need to cut down on my consumption. I need to tell somebody that I'm actually having a problem with this, or I need to tell my job and take some time off about getting help, or I need to, make arrangements for childcare if that's the need that I have. And so, many times we confuse preparation with action because people are making calls, they're making plans and that sort of thing. And traditionally we think that as action, but action is actually performing that behavioral change which we set the goal for. So in other words, action is, if my substance is alcohol, is stopping to use alcohol anywhere from 3 to 6 months, then it would be considered an action. And if the action is not using heroin, then that's the action, 3 to 6 months not using that substance. The action is going to the gym, it's performing that action 3 to 6 months, in other words, going to the gym once or twice a week, then I would be considered an action. So if that's action 3 to 6 months, then what is maintenance? Is the continuation of that behavior for more than 6 months, then a person would be considered being in maintenance. The question, or one of the questions becomes, if you are in action or maintenance and you have a reoccurrence or resurfacing of symptoms that people used or went back to old behaviors, where do people go to? And for a very long time, people in our field have thought that people go all the way back to pre-contemplation and then need to start all over again. And that's not necessarily true. People can go back to pre-contemplation and say, well, I can use and I can use safely and I don't have a problem, even though that they have. But some people can go back to preparation quickly and say, this is what I need to do to get back on my feet and into recovery. Or people can go to contemplation and say, well, I don't really believe that I have a problem, or maybe I do, maybe I don't. You see that people can go to pre-contemplation, contemplation, or preparation, and they don't necessarily need to go back to pre-contemplation. The other question that's critical in relationship to this is, can you be in more than one stage at the same time? And when I ask that question, some people say no, and then some people say yes. The answer to this is yes, you can be in more than one stage at the same time, because there are multiple behaviors that people might want to change. And so a person can say, I want to stop using heroin, and they stop using opioids, right, and move from pre-contemplation to contemplation, preparation, get into treatment and recovery for heroin, and they're in action and not doing heroin, but they might be still drinking. And so they might be telling themselves and other people, I don't have a problem with drinking. Drinking doesn't create a problem for me. And if drinking in fact does create a problem for them, they might be in pre-contemplation for their drinking while in contemplation, preparation, or action or maintenance for heroin use. Or they might be in action or maintenance regarding going to the gym, but might be in pre-contemplation for opioid use or alcohol use or methamphetamine use or that sort of thing. So you see how people can be in more than one stage at the same time. And so the question becomes for us is how do we use stages of change to help people move from pre-contemplation to contemplation, preparation, action, and maintenance, and how can we use harm reduction strategies and techniques to support that process for people? Those are really important questions for us to ask ourselves and to engage in. One of the things that we should always take into account is issues of stigma. And stigma in society in relationship to issues of substance use disorders and mental health are alive and well. And so we should be very careful with what we call people. And so you've heard the names of substance abusers, schizophrenics, homeless. These people are bipolar, they're crazy, they're alcoholics, they're crackheads, and people talk about other people in these ways, and that is really feeding stigma. Stigma is also associated with issues of harm reduction, where people go around saying, well, if you're engaged in harm reduction, that's really a crutch, or you're not really addressing the problem, or people are saying to other people, if you went from using substances and now you're using medication-assisted treatment, that's really not recovery. You just substituted one drug for another one. That is not really helpful by way of helping people to identify what behaviors they want to change and to go about changing them. When I introduced myself earlier in the webinar, I told you that I'm a person in long-term recovery. And what that means for me is that I haven't used a drug in 33 years, but that has enabled me to do is X, Y, and Z. I didn't come to this webinar to tell you that I'm an addict, because I am not that. I'm a person in long-term recovery. And so labels matter, what we call each other matter, more importantly, what we call other people matter. They have an impact on help-seeking behaviors, they have an impact on policy, they have an impact on how we develop programs and implement them at the community level. Another process that I want to draw attention to is that these terms actually dehumanize people. And we should be in a process of humanizing people and bringing people up, as opposed to placing the onus on them and saying, if you just wanted to hard enough, you would get recovery and sustain it over time. And we need to move away from that dehumanization and blaming of people for conditions that they live in, but they didn't necessarily create for themselves. That doesn't mean that we let people off the hook and that we don't hold people accountable. We do. The 23 million people across the U.S. who identify as being in recovery have taken responsibility and accountability. It is our responsibility to bring other people into the fold. And those of us in recovery, we know that at some point in time in that process of what we now call recovery, we practice harm reduction. We practice different ways of getting better. So we should look for ways of supporting people in those processes as well. And as much as possible, we should be strength-based in terms of our approach. There's a difference between calling people homeless and talking about people as folks who have experienced homelessness. There's a difference between calling people substance abusers and talking about people with a substance use disorder, or talking about people as addicts, that sort of thing, or calling people schizophrenics, like I said before. And so when we see people as not broken, but people with the potential to get better, and we focus on the strengths, on the qualities, on self-efficacy, and helping people develop those are in fact practices of harm reduction. Those are in fact practices of helping people get better, and acknowledging that we as helpers can only be there to a certain point, and that we need to be able to allow people to think for themselves, to make decisions for themselves, and our role should be a supportive one, and one that provides education and unconditional positive regard, which means that I believe in you more than what you believe in yourself, that I believe that you can get better, and I am here to be a cheerleader in that process for you and for others. And the recovery community has a huge role to play in this process. There's such a thing as we draw close to the end of this webinar as cultural self-assessments. They have been developed, and you can go to the Georgetown website, the National Center for Cultural Competency, and you will see that there are self-assessments that have been developed for individuals and organizations. They gauge the degree to which we are effectively addressing the needs of the people that we work with in diverse ways. They help us to determine our strengths and areas in need of growth, both at the individual level and at the programmatic level. And then we can plan strategically in terms of what things do we need to do to get better, including more training, more information, more of what we need to be able to support people in whatever that recovery process, those recovery processes are for folk. And here, we just want to draw attention that all credible evidence shows that there is more than one pathway of recovery. There just is. And so we should embrace harm reduction in a major part because there are multiple pathways of recovery. And to support people's pathway of recovery is not to enable them to continue whatever negative behaviors people might be involved in. My pathway is my pathway, and it works well, and it works well for me. That doesn't mean that it works well for everybody else. As a matter of fact, we can be participating in the same pathway and not utilize all of the resources or practice that pathway in the same way. And so the connection between the multiple pathways, if it hasn't been made clear to date in this webinar, I just want to be a little bit more explicit. If you come across people who still want to focus on harm reduction strategies, focus on helping them get to a place where they can get access to syringes, they can get access to condoms, they can get access to Narcan, that they can get access, because again, dead people don't recover. We should focus on the fact that recovery is not a linear thing. It is very much like the highway that we see depicted in this image, that people go in different directions and at different stages and at different speeds. And we need to be the people who understand the multiple pathways and help support people in their way of doing things. And we should hold people accountable. And there's ways of doing that. I'm reminded that motivational interviewing teaches us not to get confrontational with people, that we should roll with resistance, and that we should help people develop discrepancy in what they do and how they do it. But our role is not to dictate and say my way or the highway. I know that MI, motivational interviewing, is a topic for another different webinar, but that's a recommendation that I have for you today, to think about what other resources and things that we need to do to get better at what we're doing. I want to thank each and every one of you for electing to participate in this webinar, for answering the questions and participating in the quiz, for coming to this training with an open mind, and hopefully you have learned something that will help you help our community gain access and sustain recovery into the future. Again, thank you a great deal. Gracias, and enjoy the rest of your day.